difficult. I've very much aimed these towards the most difficult questions in your finals. I'm currently about to sit my MRCP, and a lot of these questions are more bordering towards MRCP questions, but there's no point in you being here if you know all the answers already. They're deliberately some of the harder questions that you'll get to try and push you and to try and make you learn more. You may all know all the answers already. It's also, if you've got summer exams, quite a long time before your exams. So I'm sure you'll get these all more quickly and closer to your exams as well. And again, you might know them anyway. So we'll see how we go. All right. So this was our first question. I'm going to try and launch the poll. Hopefully this will work. And if you guys pop in the answers that you put down for this question. So you are in a GP surgery and a 76-year-old man presents for his blood pressure review. He's found to have a blood pressure of 161/53. He's currently taking simvastatin, ramipril, amlodipine, and indapamide at maximal doses. His recent UNEs were as follows. So he's got a normal sodium, his potassium is pretty normal, his urea is okay, and his creatinine's also okay. So which one of the following is most appropriate? So we've got lots of people responding. Thank you for getting involved. The polls seem to work quite well, otherwise you're kind of stunned into silence and no one wants to give you any answers. So thank you to everyone who's giving it a go. I will leave it open for another second. Great. Okay, we've got about 150 responses there. So I will share the results. So as you can see, although we've got a spread of results, the most common answer that we got was B, which is in fact the right answer. So well done to all of you that got that right. If you didn't, we will talk through the results, so not to worry. Okay, so the important bits to take from this question is what medications he's on. So he is on simvastatin, which obviously, as you'll know, is a statin, not an antihypertensive, so it's not important. He's on ramipril, which is an ACE inhibitor, amlodipine, which is a calcium channel blocker, and indapamide, which is a thiazide-like diuretic. So they're the levels that he's already on. This is probably about as tricky as a hypertension question can get, but it's worth knowing hypertension inside out, back to front, because common things are common and they're going to want to test that you know how to manage it. And importantly, his potassium is 3.9, but I'll explain that in a second. So this is how I set out, I've got quite a lot of budget diagrams in this presentation, by the way, but I hope that they're useful for you. So this is how I set out and remember the hypertension guidelines. As you're probably aware, the first line is either an ACE inhibitor or a calcium channel blocker. I remember, a bit lame, but I remember ACE is more of like a young person's word. And so that reminds me that it's the less than 55s are going to be on the ACE inhibitors. The rest of them are going to be on the calcium channel blockers. Then once you've tried one of them, we're going to add in the other one for the next level. The third stage, you're going to offer a thiazide-like diuretic. It used to be thiazides at this level, so like hydroxychlorothiazide or something, but now it's a thiazide-like diuretic, of which indapamide is by far the most used. So I think that's the most important one to remember. And so they're the first three stages. That's probably what you're going to be examined on. So you should definitely know that. The next stage looks complicated, but in reality, your fourth step is probably going to be spironolactone. However, as you're probably aware, spironolactone is a potassium-sparing diuretic. So if your potassium is towards the upper end of normal, i.e. above 4.5, then we're actually going to use an alpha or a beta blocker instead. But realistically, if you mostly remember spironolactone, unless you've got the upper end of a potassium. We've got a few questions coming through. If I can answer them as I go, I will, but we'll see how they go. I've been asked why thiazide diuretics are like diuretics preferred to thiazides. So I believe there was a big RCT that compared the two. To be completely honest, I don't know the details of how they actually differ, but they've got very similar mechanism. But there was a big RCT that actually found that thiazide-like diuretics were better in hypertension, and it's just a newer version of the drug, effectively. Okay, so our next question, I will just relaunch the poll. Oh. Okay, there we go. So you are clerking a 72-year-old lady and note that she has an early diastolic murmur heard loudest at the right upper sternal edge during expiration. You note that her head is bobbing slightly while you take a history and there is pulsating of the nail bed. What is the most likely valvular abnormality? Oh, amazing. You guys are doing really well. Maybe I made them too easy, but we'll talk through all the answers anyway. Okay. We'll just wait till we get to 150 again and then we'll end it. Okay, great. So as you can see, a lot of you have put C as the best answer, which is absolutely correct. So important bits to pick out of this question are that it's an early diastolic murmur heard loudest at the right upper sternal edge and on expiration. Now, I'm going to go really, really back to basics on murmurs. I apologize if this is patronizing. Murmurs are something I don't think I fully got my head around to until the last year or so. So I was going to go back to basics so that we all had a really good understanding, even though you probably already know this, but I figured it was important that we went over this if we're doing cardiology. So proper basics. S1 is going to be when your atrioventricular valves are going to close, and S2 is going to be when your pulmonary and aortic valves are going to close. Therefore, the bit in between the two, we know is when the heart's contracting. So the time between S1 and S2, we know is going to be systole, and the time outside of S1 and S2 is diastole. So therefore, if we think about during systole, so during the contraction of the ventricles, we know that a murmur is due to turbulent flow of blood. So when the ventricles are contracting, you're either going to get turbulent flow because it's too narrow when you're getting through the aortic or the pulmonary valves, or that actually you're contracting it and it's being regurgitated through the mitral valve. So therefore, the systolic murmurs are the aortic stenosis, pulmonary stenosis, and the mitral regurg, tricuspid regurg. Now, because they're the shape of the valves, aortic and pulmonary always have a crescendo decrescendo type of murmur, which in systolic murmurs is called an ejection systolic. And mitral tends to, and tricuspid tends to more be a murmur throughout systole. Because it's a larger area, and but you just need to remember that they will always have that kind of shape. I'll go over this in a second. And then alternatively, in diastole, if we think diastole is when the ventricle is not contracting, i.e. starting to relax, so you're either going to get turbulence when the atria contracting and pushing the blood into the ventricle, and so therefore that would be in mitral stenosis, or that you've got backflow of blood through the aortic valve, and therefore that would be aortic regurgitation. Again, you've got those similar shapes. So alternatively, in aortic regurg or pulmonary regurg, it's called an early diastolic murmur, but you're still getting a kind of the loud and then quiet, but it's just that lots of it's covered by S2, versus the mitral stenosis and the tricuspid stenosis would be more throughout diastole. Now, despite all of that theory, I often get into the exam and then panic and can't remember, or a consultant's drilling me on this and I get under pressure and I can't quite remember which way around it is. So I got taught this as well, pass and paid. So this is just going to remind you that pulmonary and aortic stenosis is a systolic murmur, and pulmonary and aortic insufficiency, same as regurg, is a diastolic murmur. And I just write this down, and obviously the opposite is true for mitral and tricuspid, and this just reminds me. So if we go through that and we're still not really sure on what the quite the correct answer is, because you can't quite remember if you've got the previous bit right, there's just a few more clues in the question that are important to cover. So it was said that it was heard loudest on expiration. Now, expiratory murmurs heard loudest on expiration are most likely to be left, and you can remember that for left. And inspiratory murmurs are heard loudest inspiration makes right-sided murmurs the loudest, and the second letter in right is an I, so that's how I remember those. And finally, you can tell a bit more about what valve it is more specifically I'm sure you've seen this 100 times with where it was. And I've been taught to say all patients take medicine. I think there's various different acronyms, but that's going to give you another clue. Some other little points that might be in the question that I just thought I'd pop in about these. These are just random things that I've seen come up quite a lot about each of the different murmurs. So in aortic stenosis, I appreciate I've got a couple of questions through. I'll just have a look at them once I've finished these slides. So in aortic stenosis, the symptoms that will come up are the SAD triad, so syncope, angina, and dyspnea. So angina is often just like pain in the chest is what it says in the stem. In mitral regurg, that's the one with some of the funkier causes. So in particular, rheumatic fever is one of the most common causes, but also the connective tissue diseases. So quite often they'll pop that in the stem, something like Ehlers-Danlos, Marfan's, something like that. Mitral stenosis, you're going to get malaflush, so flushed cheeks, but you also on an ECG will see P mitrale, where the P wave is bifid. So you've got the two P waves and it looks like an M. And finally, aortic regurgitation, you get some funky signs. So you get a collapsing pulse, which I'm sure you've heard about. You also get Demusit's sign. So Demusit's sign is a head bobbing that goes with having aortic regurgitation along with the pulse. And similarly, Muller's sign is that their uvula will pulsate. Random signs, but it's something that examiners might just pop in. It'll give you an extra clue. And finally, you can also get pulsating of the nail bed. I appreciate I spent quite a long time going through all of that, but just to recap, so it was an early diastolic murmur, which we know is going to be aortic regurg or pulmonary regurg. We know it's on the right upper sternal edge, which means that we know that it's going to be aortic. And then we know it's on expiration, which is going to again confirm to us that it is a left-sided heart murmur, and then we've got the head bobbing and the pulsating of the nail bed, which are just extra clues for us. Okay, I'll go through these questions. Okay. So the I in the paid was insufficiency, which is another way of saying regurgitation. So pass and paid are your two ways of remembering it. I'll just pop it up again. So someone said, okay, so I think a couple of people just want to go back to this slide. I'll quickly pop it up. So this is the pass and the paid. So pulmonary and aortic stenosis is systolic, and pulmonary and aortic insufficiency is diastolic, or that's another way of saying regurgitation. Okay, and here we showed the crescendo decrescendo noise is seen in aortic stenosis or pulmonary stenosis, or to be honest, those valves generally, and then mitral regurgitation and tricuspid regurgitation, or those valves generally, are going to cause more of the elongated signs. Okay, you guys will get these slides if you fill out feedback at the end. So if you want to look at this for a bit longer, then you can. Okay. Sorry, I feel like I was talking quickly, getting through all of that. I will try and slow down for you all. Okay. Polls and quizzes. So I'm just going to relaunch this. So an ECG is performed on a patient presenting with chest pain. It shows ST elevation in leads 2, 3, and AVF. What is the most likely vessel impacted? Great. People have been learning their ECGs. I just thought this was an important point to cover, but we'll go over this one relatively quickly. That's great. Thank you all for getting involved in the polls. That's brilliant. Okay.
Lizzie, sorry to interrupt. I can keep an eye on the questions in the Q&A.
Oh, that's great.
Note them down and then ask you at the end if that works better.
Yes, I feel like we're getting quite a few through. So if you get a few on the same topic while I'm going through, let me know. And if not, we'll go through them at the end. Does that sound okay? Cool. So nice. We've got a spread of results, but majority for D, which is the right answer. So important bits here are ST elevation, which obviously I'm sure you all know is the sign of ischemia, i.e. STEMI, in leads 2, 3, and AVF. So if we were to put it on an ECG, leads 2, 3, and AVF are down here, and that is the territory of the right coronary artery, or it's sometimes also called an inferior MI, because that is the vessel that supplies the inferior side of the heart. So how do you remember this? This is a crude drawing of an R, but I always picture an R in this bottom corner of the ECG. And that just reminds me that that is right. Up here, you can kind of see an upside down L, but once I've remembered the R, it helps me remember that up here is where the left anterior descending artery is. Also, to remind me that it impacts the inferior part of the heart. You know, the AVF is down here, and I remember F is for feet, which is inferior in your body. There is also some sources that say that the inferior MIs are partly affected by the circumflex artery, which usually is impacted in these leads, but the vast majority of the time, this bottom corner, if they asked you about it, it's going to be a right coronary artery and an inferior MI are like the two things you need to know. Okay, so I won't dwell on that too much. Okay, next question. Your patient in question 3, i.e. the one that had the MI, represents to hospital 3 weeks following his previous admission. He's complaining of fever and pleuritic chest pain. ECG is normal. Bedside echo demonstrates a pericardial effusion. What is the most likely complication of this patient's MI? Okay. I'll give you a couple more seconds. It seems like a lot of you have seen this one before. I think this is a PassMed favourite, but I thought it was good to go through all of the complications. All right, lovely. I'll end the poll there. Okay, so as we can see, the majority of you have gone for B, which is great. So that answer is Dressler's syndrome. So I appreciate that this isn't to scale for the time periods, but this is just how I remember the different complications of an MI. There are obviously a lot of complications of an MI. These are just some that seem to come up in questions quite a lot. And I just thought it was worth going through these to begin with. Sorry, I was just looking at the chat. So we've got the immediate complications of an MI. Oh, a couple of people have raised their hand. Brad, are you all right to have a look at that?
Yeah, I'm going through and answering as many questions as I can as we're going.
If you send it through on the Q&A, then he can have a look. That might be best.
Yeah.
If you're raising your hand.
If people who want to like ask questions out loud, if you wouldn't mind just waiting to the end.
Yeah. Okay, so the immediate complications of an MI, we're going to think about, first of all, cardiac arrest, very obvious, usually due to VT or VF, and that's going to be your kind of immediate complications of an MI. You can also go into a cardiogenic shock. So that is when you get ischemia to the wall of the heart that's going to affect its ability to beat, and therefore you're not going to get effective cardiac output, and therefore you're going to go into shock. And then finally, heart block. So heart block is where you get ischemia to the electrical conduction systems, particularly the sinoatrial node in the heart. So that's more classically a right coronary artery lesion. And the majority of people, I think about 65% of people, their SA node is supplied by the right coronary artery. And so if they ask that in a question, that's what they're saying. And generally, this is managed conservatively. So unless it's an anterior MI, it shouldn't really be anterior because your sinoatrial node's on the back. So that would be a huge MI, or they're unstable. Usually you just leave it. You wouldn't manage it as heart block. You just leave them. So that's the immediate complications. Then in the next kind of 48 hours, you're going to think that it's more likely to be pericarditis. So that's just because you've had this ischemia, you've got a really inflamed heart, you're going to get the classic pericarditis symptoms, so worse on lying flat. And that will usually occur in the first 48 hours. Then you've got, within the first kind of 2 weeks, you've generally got the more structural issues with the heart. So that's going to be things like a left ventricular aneurysm is a common thing that can happen because you've got a weakening of the wall because of ischemia. The wall can then turn into an aneurysm. Now that generally presents with heart failure and an ST elevation. Often it doesn't actually have chest pain, but it will eventually lead to heart failure. But the big worry about this is you've got such turbulent blood flow within that aneurysm that there's a high risk of stroke. So you don't necessarily have a treatment for it, you just anticoagulate them. Then, if you can imagine, if you've got an aneurysm, you're at a bigger risk of a left ventricular wall rupture. And these are, of course, just some of the most common ones. The left ventricle's got the biggest pressure in it, so that's what's going to be affected first. So if you get wall rupture, as you can imagine, you'll then have blood that will spill into the pericardial sac. And so that's going to cause the symptoms of tamponade. And we'll go into tamponade a little bit later. And then we've got the other side. So this is going to be inside the heart, the structures that are damaged. So you can get acute mitral regurg, which is due to the papillary muscles get ischemic, and effectively that's the biggest valve, so that's the most likely one to be affected, and that will start to regurg. This will eventually, as with severe mitral regurg, is going to cause heart failure, and also, as we know from before, it's going to cause a pansystolic murmur because it's mitral regurg, which is systolic. Then you can also get, one of the other common complications is a ventricular septal defect. By the way, I've put a lot of notes about this in the notes under this slide. So when you get the slides through, you'll get this information as well. So you can get a ventricular septal defect. As you can imagine, like in pediatrics, you get a hole in the septum of the ventricles. Because the turbulent flow is going to be during the heart contracting, i.e. during systole, that's also going to cause a systolic murmur, and it actually very much mimics the pansystolic murmur in mitral regurg. So these are actually two common complications that you actually just need to do an echo to see which one's the issue, and they're generally surgically repaired, if that makes sense. Okay, and then finally we've got Dressler syndrome. So there are a few complications that occur later. Dressler syndrome is an important one to recognize. They seem to like it quite a lot in questions. So Dressler syndrome is caused by antibodies to the healing cardiac tissue. So after an MI, as the heart starts to heal, the body actually creates autoantibodies against it and cause an inflammatory condition. So it's actually almost rheumatological in its etiology. So you're going to see a fever because you've got this auto-inflammatory process. You're going to get pleuritis, so pain on breathing, and you're going to get a pericardial effusion because you've got so much inflammation around there. And if you were to do blood, you'd see a raised ESR. So the management is generally with NSAIDs. Often they use colchicine, but that's just going to reduce the inflammation around the heart, and that's going to treat the Dressler syndrome. I hope that makes sense. Okay. On routine bloods, a patient is found to have potassium of 2.5. Let me set off your poll. Okay. A potassium of 2.5. The guidelines state that you should check for ECG changes to decide on your further management. Which of the following ECG features is not associated with hypokalemia? Okay, nice. So we've got a spread of results, but I think the right answer is becoming most popular. Okay. Nice. So we're not as sure on this one. I'll just end the poll and share the results. Okay, so the correct answer is J waves, which half of you did get right, but we've got a few other people that picked other things, so we will go through this. So hypokalemia is a a common thing. You see it on the ward so much, and the guidelines are like, get an ECG and look out for the changes. It's the same with a lot of the electrolyte abnormalities. So actually they're things that are really useful to know for your job going forward, as well as just for the exam. Now, the way I remember this does sound quite ridiculous. My flatmate taught it to me at uni, and when she first told me, I was like, that's not useful at all. And then it's really stuck in my head. So hopefully it'll be useful for you. So there's this rhyme. I think it hangs around in the past med comments sometimes. You've got no pot and you've got no T, a long PR and a long QT. So what we're going to take out of this. So the U is going to stand for U waves. So U waves are, after you've got a T wave, you're then going to have a U wave afterwards. And we'll talk about the T waves in a second. So it's a second wave after your T wave, and it's characteristic to hypokalemia. You've got no pot, so that's going to be talk about you've got no potassium, and you've got no T, because your T waves are either just go flat, or you get T wave inversion, so your T waves aren't upwards as you'd expect. A long PR and a long QT, pretty self-explanatory, but both of them go long, and you don't see that often. So I think that's useful. So therefore, the only one that wasn't one of those was J waves. So J waves are also known as Osborn waves. They're seen in hypothermia. Okay. Right, next question. Or should be relaunched for you. So a 68-year-old lady presents with chest pain to ED. The pain came on when she was walking up a hill and settled with rest. ECG was normal, troponin was not raised, bloods were otherwise normal apart from a raised cholesterol. She was diagnosed with angina. I apologize, this is one of those annoying questions that you're like, oh, I know the diagnosis, and then it tells it to you and asks you something else. Which of the following is not part of the initial angina treatment? Okay, we've got a bit of a spread here. It's a slightly harsh question because I just mean which one is not kind of classically used for angina, but I appreciate that they might not all be used initially. Okay. All right, I'll end the poll there. So we've got a bit of a spread of answers here. So for angina management, the correct answer in this case was ramipril, which was just, oh no, it was tied as the most common. So angina management, the way that I remember it is that you've got three things that everyone gets. So everyone gets aspirin, which is going to prevent, as an antiplatelet, it's going to prevent clots happening, which is important when you've got angina anyway. A statin, because it's secondary prevention, and GCN, which is going to be your preventative that everyone's going to need to get. So they're the important three that everyone gets. Then you also want to add in something that's going to reduce the contractility of the heart. So that can be two things. That can either be a beta blocker or it can be a calcium channel blocker. And it's just important because I used to have the three cardiac drugs, beta blockers, calcium channel blockers, and ACE inhibitors, and I'd forget which one was for which treatment, but it's just important that for angina management, you would give a beta blocker or a calcium channel blocker, and you wouldn't give an ACE inhibitor. And then you'd add in the other one. I'm sure often you will know that beta blockers you can't use with verapamil, as it will cause heart block. So then when you're adding them together, you need to change it to a different calcium channel blocker. Okay, great. All right, so a known IVDU patient presents with a fever of 39. He has painless pigmented lesions on the palms, sole. I don't know, I've not written palms and soles, and painful swollen papules on his fingers. His nails are noted to have splinter hemorrhages, and on auscultation, he's noted to have a new onset murmur. What is the most likely organism to have caused this pathology? Nice. We've got a lot of you putting in answers, and 60% are getting it right. Okay. And the poll there. So 56% of you got the right answer. So the correct answer is Staph aureus. So this is just a bit of a slide for you to save with the most common pathogens. It's just quite easy marks to get for endocarditis. So obviously we're talking about endocarditis in this picture, but we'll talk a bit more about it on the next slide. So in endocarditis, in terms of the causes of it, it used to be that native valves, so i.e. just your bog standard person who got endocarditis, the most common organism would be strep viridans, which we'll talk about in a little minute. But now the most common cause is Staph aureus. So both in native valves and in intravenous drug user valves, the most common cause is Staph aureus. Generally, in the normal population, the most common valve to be affected is mitral because it's the biggest. But in IVDU populations, the most common is tricuspid. So when you get a tricuspid regurg, you're going to think, oh, is it an IVDU endocarditis? That's generally because if you think about IVDUs, the way that they get endocarditis is by injecting into their peripheral circulation. And they're going to potentially give a really high bacterial load when they do that. So therefore, when that bacteria, and they're injecting through the skin, so therefore they're going to give themselves Staph aureus most likely. And then if that travels through the body to the heart, the first valve it's going to meet is the tricuspid valve, and that's why it's most likely in IVDU populations. Prosthetic valves, the most likely pathogen is Staph epidermidis, also known as coagulase negative staphylococci. Just as an extra point, if you ever have a question about anything that we've put inside someone, a knee replacement, or kind of any device that's inside someone, and what bacteria is most likely to colonize it, it's most likely to be Staph epidermidis or cons, because it's got a function of being a biofilm, so it'll stick to it, and that's usually the most likely one to, when you put anything in someone, to colonate it. This is a bit of a past medism. Strep bovis, also known as strep galolyticus, is sometimes a sign of colorectal cancer. So if that you see that on a blood culture for endocarditis, then it's a sign that you've got to do a colonoscopy to check for colorectal cancer. And then finally, so you've got strep viridans, which used to be the most common cause generally, but is a family of bacteria that live in the mouth. So if you've got poor dental hygiene or you've recently had a dental procedure, it's the most likely to cause endocarditis if it gets into your circulation. There's a few different names for it. Staph aureus and Staph mitis are just other ones within the viridans family. But it's not anymore the most common cause in a native valve, but it used to be. What else was I going to say? I think that's, it used to be that we would offer prophylactic antibiotics for people while they're having dental procedures or if they had congenital heart problems, but it's important that that's been taken off all the guidelines now, so there's no prophylactic antibiotics for endocarditis. Okay. I said I'd go through the signs of endocarditis. You hopefully recognize them in this stem. So if we ever see someone with a fever and a new murmur, we're going to be thinking endocarditis, and as I'm sure you're aware, this is the Duke's criteria. So I just find it's quite a good way of looking back and seeing all the different things you'd look for an endocarditis diagnosis. Duke's criteria is just used to diagnose it, and you generally need 2 major or 1 major and 3 minor of the criteria. But if we just go through them, these are all features that are going to lead you more to a diagnosis. So you've got a positive blood culture with typical organisms. We've talked through what the typical organisms are. And as I'm sure you're aware, if you're worried about endocarditis, you've got to do 3 blood cultures back to back, which will be the bane of your life when you're on the wards. Then vegetations or new regurgitation on an echo. So we said a new onset murmur is going to be one of your causes. And sometimes you get vegetations, i.e. clumps of bacteria stuck to the valves. And so we order everyone with an echo who we think's got endocarditis. Minor features, so you've got your risk factors, that's going to be your IBDUs, people with congenital heart issues or valve replacements are going to be more susceptible. And then a fever, as we said, it's infection, you're expecting a fever. Then you've got vascular signs. So I used to get confused between Janeway lesions and Osler's nodes. Janeway lesions are a vascular sign, so effectively it's just a little bleed on your palm, and for that reason it's not painful. And that will go along with things like conjunctival hemorrhages, splenomegaly, that kind of thing. Then you've got the immunological side of things. So because you've got such a big infection going on, it's going to be spurting off bits of complement that go around the body and cause inflammation elsewhere. So that's going to cause your Osler's nodes, which are going to precipitate when they get to the coldest bit of your body, i.e. your fingertips. And because they're inflamed, they're going to be painful. You can also get glomerulonephritis and Roth spots. Okay, I hope that makes sense. Okay. Next one. Great. So a 65-year-old man is brought to the emergency department by ambulance. He's collapsed at home and is complaining of chest pain and palpitations. His obs are as follows. So his heart rate is 220, so he's tachycardic. His blood pressure is 89/63, so he's really hypotensive. Respirate of 18, normal temperature, and an ECG is taken. What would be your initial management? So while we're just getting the answers in, I will zoom in on the ECG. So I appreciate we're coming up to an hour now. So Brad, if you wouldn't mind putting the feedback link in the chat, just in case people need to leave early, and we'll try and put it on the Facebook group as well for you guys, if you want the slides, if you need to leave early. Okay, end that poll there. So got a little bit of a spread of results, but the most common is C, synchronized DC cardioversion, which is correct. Great. So let's talk about this. So we've got an adult with tachycardia who's got a pulse. So we're going to be using these guidelines. Hopefully you've seen these before. This guideline you need to know for when you start work. So I would have thought that it would be something that they'll want to examine you all on. And therefore I figured it was worth spending a little bit of time on it. So I used to try and learn this and I found it really overcomplicated and I just couldn't get it in my head. So I've simplified it here for you guys. So this is the Resuscitations Council if you've got anyone with tachycardia who's got a pulse. So first of all, you're going to say, have they got any adverse features? What do we mean by adverse features? So we mean heart things. So are they having an MI, or basically, again, are they having chest pain? Or are they in heart failure? So that might be in the question stem as they've got crackles at their lung bases, they're short of breath, their sats are going down. Then if they've got any syncope, so if they've had a collapse, which had in this case, and if they're in shock, so that's going to be their blood pressure's tanking, they're tachycardic, but they're obviously already going to be tachycardic. So it's usually their blood pressure tanking. They might say that they're grey, shut down, that kind of thing. So we had that in this case. As you can see, if we go back to this, he'd collapsed at home, so he'd had some syncope. He was complaining of chest pain, so that's going to suggest MI. He's also, what was the other bit? Oh yeah, his blood pressure was also low, so he was in some shock. Okay, so we're going to go straight over here. Let me get my diagram up, to the management with adverse features. So first, you're going to give them a DC shock, transcutaneous, to try and get them back because they've got adverse features. They're a really high risk of going into VT or VF. The next steps that you would do if you were down this area of the algorithm is that you try some amiodarone. First you try it stat, then you try another shock, and then you go for an infusion. You actually try 3 DC shocks before you go down to this part of the algorithm. So that's just the important bit to just remember, that if they're unstable with any of these adverse features, you're going to give them a shock, and then you're going to consider some amiodarone. Then I'll just whiz through the rest of the algorithm. So then you're going to ask, is it narrow? Is it broad? What determines narrow or broad? So you've got if it's more than 0.12 seconds, that's what they call narrow. So if it's narrow, it's going to be coming from the atria. So we know that if you've got an irregular heartbeat coming from the atria, that's going to be AF. And so you just manage that with something to slow it down initially. I know that you can do rate versus rhythm kind of long term, but initially, if they're in this level of tachycardia, we just want to slow them down. So you're going to use a beta blocker. Then, if it's regular, we're going to think, okay, it's some other kind of supraventricular tachycardia. And so how do we treat that? We're going to treat that with first vagal maneuvers, a carotid massage, or Valsalva. However, having done this in the middle of the night with a patient, getting them to, as you're meant to, get them to blow open a syringe is not very easy when they're feeling this rubbish. So often you end up moving to adenosine. As you may be aware, adenosine is the medication that you give and they feel terrible, they feel like they're going to die, but it's a really important one to remember for SVT tachycardias, and that's going to slow down the rate enough that you can do something else about it. You give it 6 milligrams, then 12, then 12. I don't think you should learn many doses. If you're going to learn one, I think this is quite a good one to learn. Just to properly look at this ECG anyway while we're here, sorry, the right slide. As you can see, there's no P waves, and it is a regular tachycardia. So it is actually, and there's some ST depression as well, which actually can be seen in AV nodal reentry. So this is just your classic SVT. So if there weren't adverse features, then you would be treating it down the vagal maneuvers and adenosine route. Then you've got your broad complex tachycardias. Now, in this algorithm, it looks quite complicated, but basically the majority of time, it's just going to be VT. The reason there's more information there is because technically, if you were to have a bundle branch block, which is going to cause your bradycardia, and a wide complex QRS, but then you get an SVT or an AF on top of it, then it can mimic a broad complex tachycardia. But I wouldn't worry too much about that, because there's not an easy way to discriminate it unless you're an experienced cardiologist. But that's just explaining why there's more information. And if you have a read of this original algorithm, it looks a bit more complicated. And the only other thing I guess to say here is this is assuming it's a monomorphic VT, i.e. they're all the same size. If you've got a polymorphic VT, that's more likely to be torsade de pointe, but we'll talk about that with a later question. Okay, so with VT, you're going to give amiodarone. As you would, it's quite similar to if they're unstable. And you give a stat and then you give an infusion, but it's just important that the DC shock is just used if they've got adverse features. I hope that makes sense. That was quite a lot of information I'm all throwing at you. I hope it's not overloaded you too much. Okay. Right, next question. A 24-year-old whose family member has recently been diagnosed with hypertrophic cardiomyopathy comes to you as he's worried about having the condition himself. Which of the following features would not suggest a diagnosis of hypertrophic cardiomyopathy? Sorry to do a negative answer, because I feel like these are a bit harsh because you need to know all the other answers, but I wanted to take a bit of time to go over what features you would see and kind of why. All right, so we've got a bit of a spread of answers here. Okay, I'm going to end the poll there, because I think we can take a bit more time to discuss this, because we've got a spread of results for the first time. So I think this is a good one, because we'll talk it all through. So the correct answer was a slow rising pulse. As I say, this is quite a hard question, so I wouldn't worry too much if you didn't get it right, but we'll just more than anything take away the answers. So hypertrophic cardiomyopathy, I've done a bit of a crude diagram of a heart here to try and explain it to you. So it's when you get the asymmetrical hypertrophy of the interventricular septum. So that's going to grow, and it grows into the left ventricle. So it means that there's not as much space for blood and it becomes stiffer. So that's going to affect your filling ability, i.e. your diastolic function. Also, as you'll see my little picture move, if you look carefully, this little bit of hypertrophy can flip up when the heart is pumping heavily, and can actually block the aortic valve. So it effectively gives you aortic stenosis or impaired aortic outflow symptoms. So, as we said before, aortic stenosis is going to give you the SAD symptoms, the syncope, angina, and dyspnea. So in this case, they can get syncopal episodes, or they can get angina, which was one of the answers in the question. The pulse is jerky due to the way that when the leaflet goes up, it can impact it, and also the stiffness of the ventricles. I wouldn't worry too much about the pulse. It was more to rule out the other ones as being correct. That was more important. In terms of a murmur, so you'll get an ejection systolic murmur, again, because we're basically emulating aortic stenosis, which we all now know is an ejection systolic murmur. And S4 is present. So what is S4? So you've got the two extra heart sounds, S3 and S4. So as you can see on this diagram, S3 is going to fall just after S2, so just after the end of systole. And it's actually the sound of the chordae tendineae stretching, because you've got excessive ventricular filling really quickly. That tends to happen in young patients, or in heart failure, or in mitral regurg, where you're really pushing too much into the ventricles. But in this case, what we've actually got is S4. So S4 occurs just before S1. And S4 is actually the sound of the atria contracting against a stiff ventricle. So in this case, we've got a stiff ventricle, as we've said, because it's hypertrophy, the muscle's just not made very well. And so that's why you get the S4 sound. Hopefully that makes sense. In terms of investigation for hypertrophic cardiomyopathy, because you've just got a huge amount of muscle around the ventricles, you're going to get prominent Q waves, and you're also going to get T wave inversion. Probably a bit advanced for what you need to know, but an echo is how you'd generally diagnose it. And the things that they're looking for in an echo, I got taught, I've seen this, it's called Mr. Sam Ash, just to remember the different findings. So MR is you get a little bit of mitral regurg because you've got such big muscle that it pushes it back. So you can see that on an echo. And also because the structure of the heart is slightly distorted, you're going to get some regurg. SAM stands for systolic anterior motion of the mitral leaflets, and that's just some of the buzzwords that they ask for, but again, this is probably too advanced. And then ASH stands for asymmetrical septal hypertrophy, which, as we've said, is the whole pathology behind it, and that's one of the important things they look for on an echo. All right, sorry if that was a bit advanced, but I just thought I'd tell you the information, you can do with it what you will. Okay, let's go on to the next poll. Well done, guys, you're doing well. We're 2/3 of the way through, and a lot of these are quicker. A 71-year-old man presents with dizziness. He has no chest pain. He has not lost consciousness. He's no shortness of breath. He's normotensive. So, as we were talking about before, he's not unstable. The ECG shows the following. What is the definitive management for this patient? Nice. Okay. So we're just about getting the right answer. Amazing. Okay, I'm going to end the poll there. Okay, and we'll share the results. So 46% of you got the correct answer, which is a percutaneous pacemaker. Okay, so this, as you hopefully have recognized, is heart block, and we're going to talk a little bit about the different types of heart block. Okay, so you probably are aware that there's first degree, second degree type 1, type 2, and third degree heart block. Now, there's different ways that you can remember the different signs of heart block. Again, I have stupid ways of remembering it, so I don't know if this will be helpful for you. I once got taught that it's almost like husband and wife, or husband or partner, and the partner is coming home. The first degree of the issue in their marriage is that they're coming home a little bit later every night. So every night they're the same amount late, they just come home half an hour late. And then as their marriage deteriorates a little bit more, the PR interval gets longer and longer each day. And then eventually one day you just won't come home. And then the next level will be, they have a discussion, they work out they need to do something to make it work. So he will come home on time most days, but then some days he just won't come home, but they've decided that that's how it's going to work. And then eventually they have a complete breakdown of the marriage, and there's no association between when he's meant to come home. I don't know if that helps you, but that is how I got taught it. And that goes through the different levels of heart block, if you can correlate them at all. So importantly, with first degree heart block and second degree heart block Mobitz type 1, you just watch and wait. You're not as worried about that. But once you get into secondary heart block, or Mobitz type 2 or third degree, then there are increased risk of sudden cardiac death. So you'd put in a percutaneous pacemaker as the definitive management. So this is importantly one of those questions where it says definitive management. So what's actually going to solve the issue? So as you can see here, we have a normal PR interval, a normal PR interval, a normal PR interval, and then a beat is dropped. So this is going to be a Mobitz type 2 ECG. This is the bradycardia equivalent of the tachycardia we saw previously. Basically, you just look for those adverse features, and you're going to give them atropine, if they have any of them. Then importantly, you need to look at a risk of asystole, and in there we've got the Mobitz type 2 or the complete heart block. So if someone presented with it acutely, you might actually think of the transcutaneous pacing, which was option number 5. But in this case, we were talking about the definitive management, so it wasn't to do with the acute management. So here we just got some explanation of the answers, which you can look through when you look at the slide yourself. I don't want to keep you for too long. Sorry that this is running over a bit. Okay. Pulls back up. A 24-year-old female presents with chest pain and shortness of breath on exertion. She's normally fit and well, but does know that she was feeling under the weather with a sore throat a week ago. On examination, she's hemodynamically stable, heart sounds are normal, oxygen saturations are 98% in room air, and she's apyrexial. Bloods are normal, other than a mildly raised white cell count, and a CRP that is also raised. Troponin was 3,000. ECG shows widespread ST elevation. Nice. People are more sure about this one, which is good. I won't spend too long on it then. Okay, I'm going to end the poll there. Okay, and share the results. So the most common answer that people put was A, which is absolutely correct. So here we've got myocarditis being the most common, most likely diagnosis. So what's myocarditis? So myocarditis is now most commonly caused by parvovirus B19, but it can be caused by a variety of other viruses. It can also be autoimmune, drug-induced by doxorubicin, which is a chemotherapy drug, or giant cell, which is an inflammatory process. How does it present? So the classic thing you'll see in the question is that they've got a viral prodrome, and then they get some chest pain. And because it's the myocardium that's infected, you're going to get a really, really high troponin. So that's what's really important. The ECG findings can be varied. So you can get ST elevations, you can get sinus tachy. I've been caught out in a question recently where it showed saddle ST elevation. And I was like, oh, fine, pericarditis, amazing. But pericarditis would be less likely to cause a sky high troponin. And so that was meant to be the giveaway, but it was actually myocarditis. Generally, if you've got a young female, I had one at work a couple of months ago that presents almost like a heart attack. A lot of the time they think, oh, it's actually more likely to be myocarditis. So when you've got a patient that's young, that's got ST elevation, just think in your head, is there any other signs of myocarditis in this question? Okay. A 22-year-old female is admitted from a mental health unit with palpitations. She has a background of anorexia nervosa and prior to admission was being managed for electrolyte abnormalities. She's also recently been commenced on the antipsychotic to manage her symptoms. On admission, an ECG was taken. Precipitating factors are corrected. What would be your next step to manage this arrhythmia? Amazing. You guys are getting this right. So this was actually a girl that one of my housemates saw in ED, so with this exact story. Okay, give you a couple more seconds. Okay, I'll end the poll there. So the most common answer was mag sulf, which is the correct answer. So as we can see here, we've got that polymorphic VT that I was telling you about before. So it goes in and out like this. And this is really characteristic of torsade de pointe. Sorry for my terrible French accent. So torsade de pointe is a ventricular tachycardia that is going to occur when you've got a variety of things wrong, generally when your QT becomes too long. So it's really important to understand, they always ask about the different causes of torsade de pointe or of just a long QT. So you've got a couple of syndromes, your Jekyll-Lange-Nielsen syndrome. I feel like PASMA just really likes these, which is basically long QT with deafness, or your Romano-Ward syndrome, which is long QT but no deafness. And they're just the two that I remember, and that's the only fact I remember about them. Generally, if your electrolytes are low, it's going to cause a long QT. So, you know, we said earlier, you got no pot, you got no T, a long PR and a long QT. It's going to be in your hypokalemia. It's also going to be in your hypocalcemia and your hypomagnesemia, importantly. There are lots of drugs. There's a list there with some examples. The ones that are really important, I would say, antipsychotics and antiemetics. They're the ones that on the ward you tend to get flagged up and you have to speak to your pharmacist about. In this case, she was anorexic, so therefore they're more likely to have lots of electrolyte abnormalities, particularly if they're going through refeeding syndrome. And she also had just been started an antipsychotic. Whenever you see that just been starting an antipsychotic, you need to have alarm bells. How's their QT? Okay, and generally to manage torsade de pointe, you're going to correct the underlying abnormality, i.e. she'd probably get an electrolyte infusion, but we said that we've already done that in the question. So they also get an IV magnesium infusion, and that's going to stabilize the QT and shorten it. Okay, nearly there. Well done. You're doing really well. Okay, stop sharing. A 53-year-old man presents with tearing chest pain radiating to his back. Upon taking his observations, you note that his blood pressure in his left arm is 146 and his right arm is 82. When taking his blood pressure, you note he's very tall with long spindled fingers. He's stabilized and you wish to determine the cause of his chest pain. What's the most important investigation to choose for this likely condition? Amazing. Well done. Okay. We're just over 100 there. I'll end the poll. Okay, and we can see the most likely answer is CT angio, which is absolutely correct. So this gentleman has a tearing chest pain radiating to his back. So that's should immediately make you think, oh, maybe this is an aortic dissection. He's then also got different blood pressures in each arm, and we'll talk about that in a second. And he's got tall, long spindle fingers. They're all the important things to take out of the question. Okay. So aortic dissection, as we said, it's a central chest pain. They can describe it as ripping, feels like it's radiating to the back. You can, because you get a rip in the aorta, it can, and it's more likely to be over here, it's going to cause that you likely will have already had the blood supply to this arm would have come off, and then the blood supply on this side, it won't be getting anything down to the arm, which is why on your right hand side you might have a low blood pressure, and on your left it's trying really hard to pump everything out because you're shutting down, and then you'll have a high blood pressure on the left over here. Okay. And you can get some site dependent effects. So depending on where it rips, it might have slightly different impacts on what's more ischemic. So the important thing is to investigate it. We're going to do a CT angio. It makes sense. We want to see what's happening to the blood vessels. You can, if they're really unstable, the other option is to do an echo, because then you can see a good image of it all. But if they're stable, a CT angio is the gold standard. In terms of the management, so you may have seen this before. So a Stanford type A and type B is how it's split up, and that's going to tell you a bit about the management of the two. So if it's in the first 2/3 of the arch, i.e. ascending for A, then you're more worried that there's a chance that the the coronary arteries are going to be impacted. And therefore you're going to get cardiac ischemia. So you're going to treat that more aggressively, i.e. with labetalol to lower the blood pressure, but also with surgery. So the labetalol is going to stop them bleeding out as much because the blood pressure is going to be lower. But then you're going to also need to do surgery because you don't want it to keep ripping and then affect the coronary arteries. Whereas if it's in the descending side, or a Stanford type B aortic dissection, you're less worried. So you just control their blood pressure. Okay, 2 more to go. Right. You are performing a NIPE on a 6-week-old baby. The parents are worried about a bluish discoloration into their skin. On examination, they have an ejection systolic murmur on the left sternal edge. An X-ray reveals a boot-shaped heart. Following the echo, they are diagnosed with tetralogy of Fallot. Again, sorry, you probably were like, boot-shaped heart, I know that, and then I've told you the answer. Which of the following is not a feature of tetralogy of Fallot? Oh, amazing. You guys know this. 88% of you have got this right. Amazing. I've spent ages doing these pictures though on the next few slides, so we'll go through them, but we'll go whiz through them quite quickly and then we'll nearly be done. Okay, I'll end the poll there. So the correct answer is mitral regurg, and we'll talk a little bit about why that is in a second. So the way that I like to remember the different features of tetralogy of Fallot is, again, here is my very budget drawing of a heart. So this would be your standard heart, but it's not going to form effectively in the womb. So first, you're going to get a ventricular septal defect. So that's going to be your first sign. That's the one you need to remember. If you've got a ventricular septal defect, that's then going to lead your aorta to move more over to your right side of your heart because the septum's not formed quite correctly. So it's going to push the aorta over into this side. And that's going to mean that blood is going to flow both through your pulmonary artery, but also blood from the right side of your heart is going to go up into your aorta as well. Then you're going to get some pulmonary stenosis because your aorta is overriding so much that there's no space for the pulmonary artery. So you're going to start crushing that. And then finally, because this right side of the heart is trying to push against some pulmonary stenosis, it's going to get hypertrophied. So that's the 4 features that you need to remember of tetralogy of Fallot. Okay. Final question. So a 56-year-old woman presents with chest pain, worse than leaning forward. She's treated for pericarditis. You're asked to review her as she's become hypotensive. On examination, her heart sounds are muffled and her JVP is raised. What complication of pericarditis is most likely to have occurred? Amazing. We'll whiz through this one. 97% of you have got the correct answer. Perfect. Well, we'll end on a high. Okay, so the correct answer is cardiac tamponade. definitely good that you recognize this because it's an absolute emergency. I don't think I can ever explain it better than this picture, which just made it click in my head, and hopefully you guys have all seen this before. So you're going to get fluid around the heart, which is going to mean that you're going to get a back pressure into your JVP. So it's going to give you a raised JVP. You're going to get hypotension because there's too much pressure around the heart that nothing will flow out. And then you're going to get muffled heart sounds because the heart is trying to beat inside a big bag of fluid. As you can see here, that is called Beck's triad, but he's muffled, so he's saying Beck's triad. And I think this is really useful for remembering the triad of cardiac tamponade. Okay. So well done for all sticking with that. That was a long session. Apologies for it being so long, but we wanted to make sure you really had an idea of how the sessions worked and where how they would all go. If you can all fill out this feedback form, we've got it in the chat as well, if you can't click on it from here. If you can all fill out the feedback form, and then we'll send through the recording and the slides in the next few days. And then you can have them all to look through at your leisure as well. Sorry, I went quite quickly, but I just didn't want to keep you for too much of your evening. We also we'll be having sessions in the upcoming weeks. It's all linked to the MLA curriculum, so we'll be going over loads of topics. So have a look at our Facebook page at www.facebook.com/Thursday15s, and you can see all of the events on there for the upcoming weeks. Cool. So should we go through some questions, or have you got anything to say?
So basically what I've left in the Q&A box a couple of the questions that I were related to specific things in the presentation, and I can remember. A couple of other things that came up quickly, which I think we kind of half got to the bottom of in the chat, was that for adenosine, I can't remember which one you said. I can't remember if you said 6-12-12 or 6-12-18, but a couple of people were questioning whether you give 6-12-12 or 6-12-18. And from a little bit of digging, I've seen that there's some contradictory information in it. Basically, BNF recommends 6-12-12. New recommendations from Resus Council say 6-12-18.
Oh, fair enough. Maybe it's changed since I got this.
Yeah.
Picture.
So likely 6-12-18 is the new official one, but as it's been changed so recently and it's still wrong in the BNF, they won't test you directly on it, and they definitely won't give two options, one of which is 6-12-12, one of which is 6-12-18, because that would be really mean. And the other thing that came up a couple of times were a couple of people just mentioned what you couldn't have with verapamil, and you can't have verapamil and a beta blocker because of the risk of total heart failure. And those are the kind of two things that came up a couple of times, and then the rest of the questions are there for you, Lizzie.
Great. So I'll go through a few of these. So one of the questions, I think when we were back on the angina slide, is does this not depend on if it is stable or unstable angina? So it does, yes. This would be the stable angina management. Often people are going to be presenting with angina first. Yeah, sorry, I didn't stipulate, but this is going to be a stable angina. Once you go into unstable, it's treated under ACS. So this would be stable angina treatment. Could you please explain why ACE inhibitors are not involved in angina management? Now, leave that one with me. I will send it out with the slides. I don't want to tell you wrong, but it's to do with ionotropic activity and what's going to cause heart contraction versus affecting blood pressure. ACE inhibitors are more to do with your RAS system, I believe, but I'll get you a good explanation and send it out with the slides because I don't want to trip it up and confuse you more. Okay. What is native valve compared to normal population? So native valve is just what they tend to call a normal population valve in endocarditis. They say native because it's your own valve. It's not prosthetic, is basically all that means. 2 months prosthetic, I believe that's because if it's more than 2 months that you've had the prosthetic valve, you're more likely to get it colonized, is where that was from. What cons, please? I can't quite work out what that was from. Apologies. But if you know and you're still here, feel free to pop it in. Sorry, I missed the answer to question 8. So the answer to question 8 was synchronized DC cardioversion. So this was about having an unstable patient, and therefore they'd fall down the unstable side of the algorithm. Okay, we've got a few kind of just duplicated stuff. What is the answer to 11? You'll get all the slides, so if you've missed any of the answers, then you can see them there. The answer is myocarditis, which you can see there. What resource would you recommend for learning ECGs? So Life in the Fast Lane is really good. That's where a lot of these ECGs have come from. They give really clear explanations and then give you some practice questions at the bottom to go through them, and have quite a lot of MCQs on their website about going through. So that's the best place I would go for ECGs. They're not easy. It's never been something I enjoy, but I think taking some time to go through them and kind of understand them properly is really important. I could have done a whole presentation on ECGs today, but I've tried to do a bit of a mixture of the cardiology. How do you best measure a raised JVP? Is it easy to spot? So let me make sure I get this right. So to look for a raised JVP, you're going to draw a line. You have them at 45 degrees. You draw a line directly up from their joint in their sternum, and that's then you draw a line across to where the JVP is, and it should be no more than 4 centimeters in height, if that makes sense. And then that should see where your JVP should lie. I hope that makes sense. Look at a diagram online, because it's fairly clear. In reality, do you actually do that? Probably not. You tend to just see if you can see their JVP kind of lying in the middle of their neck. Okay. So someone's asking about getting the slides sooner rather than later. We'll send them out later this week, so I wouldn't worry. We'll get them out for you as soon as possible. So don't worry, you'll have them in time for your finals. So we've got quite a few. I'm trying to cover most of them with straightforward answers. Can I ask, for AF, is anticoagulation for 3 weeks not needed if rhythm control is pharmacological? Unless it's DC cardioversion. My understanding was if you're doing rhythm control, so when you're saying pharmacological rhythm control, I'm assuming you're talking about kind of flecainide. Flecainide doesn't need anticoagulation, but then you do have, I believe you can also use amiodarone for it. I'm not entirely sure, to be completely honest, about whether you anticoagulate for that, but my understanding was that you don't. I thought it was just for DC cardioversion, but that is something I'm not entirely sure on. Apologies. Is there a link to the feedback form? I can't scan the QR code. It was put in the chat if you're still here and wondering about that.